Hello and welcome back to the College of Natural Health Sciences Bermuda, the Induction Prep course. This is week number 5. And today we will be looking at Chapter 4 in the Functional Anatomy textbook, and we are going to be taking a very close look at the shoulder. The learning objectives for today's lecture are to identify the main structures of the shoulder, including the bones, joints, special structures, and deep and superficial muscles. We're going to label and palpate the major surface landmarks of the shoulder. We're going to identify and demonstrate all actions of the shoulder, meaning the movements that are available. We're going to identify and demonstrate passive and resisted range of motion of the shoulder. We're going to draw, label, and palpate the deep and superficial muscles of the shoulder and name their actions. Palpation should include the origin, insertion, muscle belly, and demonstration of shortening and lengthening of the muscle. We're going to describe the function of each of the muscles of the shoulder. We're going to identify both the synergists and antagonists involved in each movement of the shoulder, such as flexion and extension. We're going to identify movements and muscles involved in coordinated activities of the shoulder, such as reaching, lifting, throwing, and pushing. We begin our study of the shoulder by first taking a look at the surface anatomy. And here we have a diagram of the anterior view. At the most superior, the top, we see the deltoid muscle. The deltoid muscle is a prominent muscle visible on the front of the body. Over to the left, we see the biceps brachii. The biceps brachii is visible in the center of the anterior arm. The anterior border of the axilla, or armpit, is formed by the pectoralis major muscle. The pectoralis major muscle has attachments on the clavicle and sternum, supporting the shoulder girdle at the anterior midline. And just beneath, still on the left, we have the serratus anterior, which attaches to the scapula and the ribs, and it acts as an important stabilizer of the shoulder girdle and an accessory muscle of respiration. Over to the right, we see the clavicles, or collarbones, and they are horizontally oriented, slender, and S-shaped. They provide a bracing system for the front of the shoulder girdle. The clavicles articulate with the sternum, or the breastbone, in the center of the body. This vertically oriented bone provides a broad attachment point for several muscles and protection for the organs underneath. It forms the front of the rib cage. Now let's consider the surface anatomy of the shoulder from the lateral view. The Acromion process is the prominence that forms the superior and lateral corner of the scapula. It sits above the rounded mass of the deltoid muscle, where it connects with the lateral clavicle. The triceps brachii is visible posteriorly on the arm. Considering the posterior view of our surface anatomy of the shoulder, we see the trapezius muscle, which is a large muscle, triangular shaped, and it covers the back of the neck and shoulder girdle. The scapula, or the shoulder blade, is a flat bone that glides along the rib cage to form the scapulothoracic joint. This is not a true joint, as muscles separate the scapula and the rib surfaces. The latissimus dorsi is visible as a large flat muscle on the trunk posterior to the arm. Now let's consider our surface anatomy of the shoulder from a superior view. The spine of the scapula is a prominent ridge that divides the scapula diagonally. It forms an attachment point for the trapezius and the deltoid muscles. The deltoid muscle has attachments on the spine of the scapula, the Acromion process, and the clavicle. Now let's take a look at the skeletal structures of the shoulder from an anterior view. Beginning from the left at the very top, we see the acromioclavicular joint. It is formed by the articulation of the acromion process of the superior scapula with the lateral clavicle. Just a little further down on the left-hand side, we see the coracoid process. The coracoid process of the scapula protrudes anteriorly and inferior to the clavicle to form a strong bony attachment for several muscles of the shoulder. Just a little further down, we see the glanoid fossa. The glanoid fossa is a shallow depression of the scapula, and it forms the socket of the glenohumeral joint, which is the articulation of the glanoid fossa with the head of the humerus. The glenohumeral joint is commonly called the shoulder joint. Over to our right, at the top, we see the shoulder girdle. The shoulder girdle is comprised of the clavicle and scapula bones. The shoulder girdle is also referred to as the pectoral girdle. The sternoclavicular joint is the articulation of the medial clavicle with the manubrium of the sternum. The manubrium is the most superior portion of the sternum. The sternum articulates with the ribs via the costocartilage to form the anterior of the slightly movable rib cage. Now let's consider the lateral view of the skeletal structures of the shoulder. At the very top, we see the scapula. The fact that the scapula articulates only at the small acromioclavicular joint allows for a wide range of motion possible at the shoulder. Down to our left, we see the combined motion of the scapulothoracic joint and the glenohumeral joint, and it is called Scapulohumeral Rhythm. The epicondyles of the humerus form prominent attachment sites for muscles of the elbow and forearm. And over to the right, the anterior surface or the undersurface of the scapula is somewhat concave, forming the subscapular fossa. This depression is the origin of the subscapularis muscle of the rotator cuff. Now let's consider the skeletal structures of the shoulder from the posterior view. There are two depressions on the posterior scapula. The one superior to the spine of the scapula is called the supraspinous fossa, and the one inferior to the spine is the infraspinous fossa. The diagonal spine of the scapula extends laterally and superiorly to form the acromion process at the superior shoulder. The scapula rests on the musculature of the rib cage, but does not truly articulate except at the acromioclavicular joint. The connection between the scapula and the rib cage is nevertheless called the scapulothoracic joint. The superior view of the skeletal structures of the shoulder highlight the manubrium of the sternum, the sternoclavicular joint, the clavicle, the acromioclavicular joint, the scapula, and the acromion process. And these are the bony landmarks of the shoulder region that we can palpate, beginning with the clavicle, the sternum, the acromion process, the coracoid process, the greater tubercle, the bicipital groove, the lesser tubercle, the deltoid tuberosity, the scapula, the medial border of the scapula, the superior angle of the scapula, and the lateral border of the scapula. Now let's consider the ligaments of the shoulder region from the anterior view. The Coraco-clavicular ligaments attach the inferior distal clavicle to the coracoid process of the scapula. The coraco-acromial ligament connects the scapula's coracoid and acromion processes. It stabilizes the humeral head during overhead movements. Then we have the glenohumeral ligaments, and they help to hold the proximal humerus in the glanoid fossa of the scapula. The sternoclavicular ligament anchors the medial end of the clavicle to the manubrium of the sternum. And here we see the lateral view of the ligaments of the shoulder. The ligaments of the shoulder girdle lie at varying angles to limit movement in multiple directions. The vertically oriented coracoclavicular ligament prevents the clavicle from raising superiorly, while the horizontally oriented acromioclavicular ligament prevents separation between the acromion process and the lateral clavicle. The cartilaginous glenoid labrum covers the edges of the glenoid fossa, cushioning the glenohumeral joint. The posterior view of the shoulder region highlights the coracohumeral ligament. This ligament tethers the humeral head to the coracoid process of the scapula, creating tension and stability when the arm is resting at the side. Taking a look at the ligaments of the shoulder region from the superior view, the V-shaped structure formed by the coracoacromial ligament can be seen from above. This structure limits displacement of the humeral head in the glanoid fossa as the supraspinatus and the deltoid muscles abduct the glenohumeral joint. The converging fibers of the coracohumeral ligament and glenohumeral joint capsule can be observed from this view as well. There are also some special structures of the shoulder region that we will highlight here, beginning with the common carotid artery, and next to it we have the internal jugular vein. Over to the left, we see the axillary lymph nodes, which resides deep in the axilla, filtering lymph from the upper extremity. We also see the brachial artery, which carries oxygen-rich blood from the larger thoracic arteries into the upper extremity. The brachial vein, it returns oxygen-depleted blood from the upper extremity to the larger thoracic veins for transport to the heart. The subclavian artery and vein are deep to the clavicle and serve the extremity. The brachial plexus, which is a large bundle of nerve fibers, run deep to the clavicle and pectoralis minor muscles before descending to the arm. Now let's consider the bursae of the shoulder region. Over to the left, the subacromial bursa separates the glenohumeral joint capsule and the acromion process. The subscapular bursa lies along the inferior surface of the glenohumeral joint and separates the joint capsule and the tendon of the subscapularis. Also, the inferior portion of the glenohumeral joint capsule is lax when the arm is neutral and taut when the arm is overhead. Now let's consider the superficial muscles of the anterior shoulder region. First, we see the trapezius at the very top or superior. It is superior to the deltoid, followed by the pectoralis major, the Coraco brachialis, the Biceps Brachii, and the serratus anterior. And here we have the superficial muscles of the posterior shoulder region. We can clearly see the trapezius, the deltoid, the infraspinatus, the teres minor, the teres major, the latissimus dorsi, and the long, lateral, and medial heads of the triceps brachii. And here we see the deep muscles of the shoulder from an anterior view, beginning with the subclavius, the subscapularis, the teres minor, the Coraco brachialis, the teres major, the Pectoralis minor, the serratus anterior, and the biceps brachii. The deep muscles of the posterior shoulder region are the levator scapula, the rhomboid, the supraspinatus, the infraspinatus, the teres minor, the teres major, and the triceps brachii. Now let's consider the techniques that we use to palpate muscles. First, we locate the origin. Second, we look at the location of the insertion, followed by the location of the muscle belly. We activate the muscle by using resistance. We shorten the muscle and we lengthen the muscle. And here we have illustrated the axial muscle attachments from the anterior view. The rib cage forms a stable attachment for several muscles of the shoulder. Large prime mover muscles, such as the pectoralis major, have broad origins, and we see them highlighted in red here, and they attach on the rib cage, and the smaller insertions, which are highlighted in blue, attach at the humerus. And here we have the anterior view of the appendicular muscle attachments. Primarily, muscles working on the glenohumeral joint originate on the scapula, which are the areas that are highlighted here in red, and they insert distally on the humerus, which are the areas highlighted in blue. The more mobile humerus tends to move toward the more stable scapula. And here we have the appendicular muscle attachments from the posterior view. The posterior scapula provides several attachment sites for muscles of the shoulder. The prominent spine is leveraged by the large trapezius and deltoid. The rotator cuff muscles that stabilize the glenohumeral joint fill the fossa above and below the spine. Now let's take a look at the movements that are available at the scapulothoracic joint. Diagram A illustrates elevation. Diagram B illustrates depression. Diagram C, retraction. Diagram D, protraction. Diagram E, upward rotation. And diagram F, downward rotation. Now let's take a look at the movements that are available at the glenohumeral joint. In diagram A, we have flexion. Diagram B, extension. Diagram C, abduction. Diagram D, adduction. Diagram E, internal rotation. Diagram F, external rotation. Diagram G, horizontal abduction. And diagram H, horizontal adduction. Now let's talk about the purpose of the passive and resisted range of motion techniques that you will use as a therapist. Passive range of motion helps establish health and function of inert structures, such as the joint capsule and the ligaments. It allows evaluation of relative movements between the scapulothoracic and glenohumeral joints. Resisted range of motion helps establish health and function of dynamic stabilizers and prime movers. And they help to identify balance and potential imbalance between muscles that steer the scapula, stabilize the humeral head, and move the humerus. So in the illustrations that we have before us, the therapist is performing passive motions of the shoulder. Diagram A illustrates passive flexion. Diagram B illustrates passive extension. Diagram C, passive abduction. And diagram D, passive adduction. In our passive motions of the shoulder continued, in diagram E, the therapist is performing what is referred to as passive internal rotation. In diagram F, we see passive external rotation. In diagram G, we see passive horizontal abduction. And in diagram H, we see passive horizontal adduction. Now let's take a look at resisted motions of the scapula. In diagram A, we see the therapist is using what is referred to as resisted scapula elevation. In diagram B, resisted scapula depression. In diagram C, resisted scapula retraction. And in diagram D, resisted scapula protraction. Now let's take a look at resisted motions of the shoulder. In diagram A, we have resisted shoulder flexion. In diagram B, we have resisted shoulder extension. In diagram C, we have resisted shoulder abduction. In diagram D, we have resisted shoulder adduction. In diagram E, we have resisted shoulder internal rotation. And in diagram F, we have resisted shoulder external rotation. As mentioned earlier, muscles of the scapulothoracic and glenohumeral joints work together to perform common movements such as reaching, lifting, throwing, and pushing. This coordinated action is called Scapulohumeral Rhythm. Smooth movement relies on proper timing of muscle contractions of multiple muscle groups. Some of the movements require moving body parts or objects through space, while others involve moving the whole body against gravity. Concentric muscle contractions generate movement, whereas eccentric contractions serve to slow and control movements of the arm. In the picture, we see the young lady who is reaching for a book. Several muscles must work to pull the arm up and overhead and then lower the object against gravity. These include the muscles that stabilize the humeral head, such as the supraspinatus, the infraspinatus, the teres minor, the subscapularis, and the biceps brachii. Other prime movers are involved as well, such as the anterior deltoid, the Pectoralis major, and the trapezius. Lifting is an example of muscles using 4 coordinated movements at the shoulder. The glenohumeral joint and the shoulder girdle must work in concert with the core of the body and arm to lift objects from the ground. The rhomboids and trapezius retract the scapula, while the deltoid, latissimus dorsi, teres major, and biceps brachii stabilize, abduct, and extend the humerus. Throwing is one of the most complex motions of the upper body. Throwing requires coordinated, powerful muscle contractions along with deep stabilization of the glenohumeral joint. The rotator cuff muscles stabilize the humeral head, while the powerful Pectoralis major, Latissimus dorsi, Anterior deltoid, and Triceps brachii pull the arm forward and across the body. Once the ball is released, the posterior deltoid, the teres minor, the infraspinatus, the rhomboids, and the trapezius must eccentrically contract to slow the motion of the arm. These agonist and antagonist muscles work together to make this motion fluid and effective. Push-ups are another example of 4 coordinated movements at the shoulder. Because the hands are planted on the ground, activities such as push-ups require fixation of the scapula on the thorax while the glenohumeral joint moves through its range of motion. The trapezius, rhomboids, pectoralis minor, and serratus anterior anchor the scapula while the anterior deltoid and the pectoralis major move the body up and down. So we've reached the end of our lecture. We're going to summarize the main points. 6 bones contribute to the shoulder. These include the paired clavicles, the scapulae, and the right and left humerus. The 2 main divisions of the shoulder are the shoulder girdle and the glenohumeral joint. The shoulder girdle is made up of the clavicle and the scapula, which articulate at the acromioclavicular joint. The medial ends of the clavicles meet the manubrium of the sternum, a bone of the thorax. The glenohumeral joint is the articulation of the glanoid fossa of the scapula with the head of the humerus, the bone of the upper arm. This joint is commonly referred to as the shoulder joint. The scapulothoracic joint is not a true joint, as there is no bony articulation between the scapula and the thoracic cage. Instead, the scapula glides on thoracic musculature. Muscles that attach to the scapula enable several motions, including elevation and depression, retraction and protraction, and upward rotation and downward rotation. The potential movements of the glenohumeral joint include flexion, extension, abduction, adduction, internal rotation, external rotation, horizontal abduction, and horizontal adduction. Passive range of motion, PROM, helps establish the health and function of inert structures such as the glenohumeral joint capsule and the ligaments of the glenohumeral, the acromioclavicular, and the sternoclavicular joints. It also allows the therapist to evaluate the relative movements between the scapulothoracic and glenohumeral joints. Resistive range of motion, RROM, helps establish the health and function of the dynamic stabilizers and prime movers of the scapulothoracic and glenohumeral joints. Evaluating functional strengths and endurance helps the therapist to identify balance and potential imbalance between the muscles that steer the scapula, stabilize the humeral head, and move the humerus. The deeper, smaller muscles in the shoulder region, such as the rotator cuff muscles, tend to stabilize the joints. The larger, more superficial muscles, such as the pectoralis major, create powerful movements. Coordinated movement of the muscles of the shoulder girdle and glenohumeral joint is called scapulohumeral rhythm. Muscles of the shoulder girdle and glenohumeral joint must work in harmony to create movements such as throwing, reaching, lifting, and pushing. Okay, so your assignment for this week, assignment number 4 from the Functional Anatomy textbook, but of course we know this is week number 5. First, you're going to list the bones that make up the shoulder region. You're going to list the joints of the shoulder region and state the type of joint for each one listed. You're going to name the 4 muscles that make up the rotator cuff. You're going to state the movements that are possible at the scapulothoracic joint. You're also going to state the movements that are possible at the glenohumeral joint. And you're going to provide a definition of scapulohumeral rhythm. You're going to also perform a self-examination. And when I say self-examination, I mean you're going to assess scapulohumeral rhythm on your own person, and you're going to report the results in your assignment, but you're also going to leave a comment in the comment section just indicating what your findings were. And I'm giving you a lot of leeway where this is concerned, so don't get too stressed out about, am I doing it right? Just go ahead and perform a self-examination and let us know what you found. So when it comes to scapulohumeral rhythm, you may say, you noted some differences in your more dominant side versus your less dominant side. So if you're right-handed per se, you may have found that the movements were more fluid, or you may have found that they were more stiff. I don't know, but it's up to you to decide how you would like to perform the examination and then report your results, okay? So do take care, and I look forward to reading your assignments and seeing your comments in the comment section below. Take care.